This conference will now be recorded.
Today, we are going to discuss the topic on approach to a wheeze in a child and also on bronchiolitis. See, this is somewhat lengthy class only, that's why I'm starting early. So, we all know wheeze is a very common presentation in your OPDs, mostly during this period of rainy season and also during winter season. One must know how to approach to a child with wheeze. So, see, the common condition that we know where the wheeze occur is asthma, right? And also another condition, bronchiolitis. But we should not pertain ourselves. The wheeze only is due to those two conditions. Wheeze could be due to so many other causes even. So one must know when a child presented with a complaint of wheeze, how to approach. So wheeze is a very important topic. One must know wheeze is seen in bronchial asthma, but all the wheezes are not due to bronchial asthma. There are so many reasons. Today we are going to discuss all those reasons. What could be the cause of that wheeze and how to appropriately approach to a child with wheeze. Am I audible and clear? Please someone answer. Am I audible and clear?
Yes, ma'am.
Yeah. So coming to the intro part, you all know wheeze is a continuous and musical sound that originates from oscillations in narrowed airways. So everyone will ask, what is the reason for the wheeze? We'll tell this is a continuous musical sound. Why it occurs? Due to constriction of bronchi, usually the larger bronchi. So because of that obstruction, when the air is expired, then a typical note is produced that we call it as wheeze. It is mostly heard in expiration due to critical airway obstruction. This point one must remember, it is mostly heard during expiration because air entry will be easy. When it is coming out due to obstructed airways, this typical wheeze you can observe. It is usually a sign of intrathoracic airway obstruction. So the next question is, what is the sound produced due to extrathoracic airway obstruction? That is larynx and also trachea. That is called as stridor. So during your clinical presentation in your OPDs or when you are approaching a child with any abnormal respiratory sounds like wheeze or crepitations or stridor, one must know what it is and why it is produced. Wheeze is a sound produced due to intrathoracic airway obstruction. Stridor is due to extrathoracic airway obstruction. Stridor could be inspiratory or expiratory. Wheeze is mostly heard in expiration. That is not like it doesn't hear in inspiration, but it is mostly here during your expiration phase. That is very important. So the next is you hear usually the terms called as polyphonic wheeze and also monophonic wheeze. What do you mean exactly by polyphonic and monophonic? See, if there is widespread narrowing of airways leading to various levels of obstruction to airflow, like it is not like same entire obstruction is like a similar way. At various levels, you can appreciate some obstruction. It results in different types of pitches that produce this wheeze. So sounds of various pitches you can hear in a polyphonic wheeze. That is typical for bronchial asthma. In a monophonic wheeze, it is produced in larger airways during expiration. That is the thing for all the wheezes. It is seen in like distal tracheomalacia and bronchiomalacia. In distal tracheomalacia or bronchiomalacia, it is like the lack of cartilage present or trachea or bronchi. So that is not like varied obstruction. It is like uniform obstruction. That is because due to cartilage deficiency. So in those conditions, you hear only single pitch. You will not appreciate different phases of obstruction at different levels that produces polyphony. So there are two types. One is polyphonic wheeze. Another one is monophonic wheeze. Polyphonic wheeze, the classic example is bronchial asthma. Monophonic wheeze, example is bronchomalacia or distal tracheomalacia. So till now we discussed definition of wheeze and also the types of wheezes with different pitches, what you can hear with the typical examples of in each type. So next, usually infants and children are more prone to wheeze due to their airway mechanics. That is, what happens is, we all know resistance is inversely proportional to the radius of the tube power 4. So what happens if the radius of tube, or for suppose bronchial wall thickening, even a small slight difference or small obstruction can lead to tremendously increase the resistance of the airway. And one more thing, why this happens more during infants and also in children are, like, more than less than 5 years, the peripheral airways caliber will be very small, and it almost contributes up to 50% of airway resistance. So any small obstruction can causes drastic increase in airway resistance, resulting in this wheeze. So usually the children of less than 5 years are more prone to have wheeze, and also more prone to have bronchial obstruction. And also marginal additional narrowing can also cause further flow limitations and subsequent wheeze. And also complaint chest wall, especially newborns, lead to intrathoracic airway collapse due to inward pressure produced in expiration. This is one of the physiological mechanisms that newborn babies are more prone to have those intrathoracic airway collapse, leading to these more in infants. Another one more thing is differences in tracheal cartilage composition and airway muscle tone causes further increase in airway complaints. These 3 points are physiological points that why the children less than 5 years or infants are more prone to have this particular wheeze because of the diameter changes and also chest wall complaints and also the tracheal cartilage composition. All these differences leads to children of less than 5 years to more prone to wheeze. The same thing. So I already told you there are so many reasons that why wheeze occurs in a child. Out of these, we already discussed like the mechanics, the three mechanics, the tracheal cartilage composition, as well as complaints of chest wall, and also the radius that and the resistance part. The most important other part is like immunological and molecular influences. See, infants have increased levels of lymphocytes and neutrophils in bronchoalveolar lavage fluid. Variety of inflammatory mediators have been implicated, like histamine, leukotrienes, interleukins, etc., in causation of this particular wheeze. All this causes hyperactive airway, leading to bronchial obstruction. And also, some programming effects like fetal and early postnatal programming affects the structure and function of fetal lung by factors including fetal nutrition, fetal and neonatal exposure to maternal smoking. These are all the predisposing factors. So from this part, it will be like useful to you. Till now we already discussed what is the type, what are the types, what is the definition, what could be the probable mechanisms or factors influencing in production of that particular entity called as wheeze. So now we are moving ahead with differential diagnosis. What could be the reasons to cause this wheeze? First, the common thing you all know is like infections. The most common infection is respiratory syncytial virus causing bronchiolitis. Bronchiolitis, that is inflammation of bronchioles, resulting in bronchial wall edema obstruction, thereby subsequently producing the wheeze. And also other viruses that can produce the entity called bronchiolitis are human metapneumovirus, influenza and parainfluenza virus, adenovirus, and rhinovirus. Other infections that can also cause are tuberculosis, chlamydia trachomatis, and histoplasmosis. So one another entity is asthma. You all know asthma, that typically the child presents almost with a condition called as wheeze. There are like the types of wheezers we'll discuss in brief in the further slides, but you have to know by that time the nomenclature, what is like transient wheezer. Here the risk factor is primarily the diminished lung size. Persistent wheezers, I'll explain each and every terminology, what is a transient wheezer, what is a persistent wheezer, and what is a late onset wheezer in subsequent slides. Persistent wheezers, the cause of this persistent wheezers like initial risk factors being passive smoke exposure, maternal asthma history, persistent rhinitis, eczema less than 1 year of age, increased IgE levels in first year of life. At an increased risk of developing clinical asthma. Usually the persistent wheezers are at more risk of developing asthma in their future life. Another entity is late onset wheezer. Don't worry, we'll discuss all this terminology. And also the anatomical abnormalities. What are the anatomical abnormalities that can produce wheeze? One already I discussed, like malacia of larynx, trachea, and bronchi. Any tracheoesophageal fistulas, laryngeal cleft that leading to aspiration can also cause, that exaggerated GR can also cause wheeze. These are the anatomical abnormalities. Another one more entity. See, airway obstruction. Till now we discussed like bronchial obstruction. It could be due to hyperreactivity or anything that is like in part of the bronchi getting obstructed, producing a typical wheeze when the air is expiring out. Here in extrinsic airway abnormality, the same thing will happen, but the bronchi is getting obstructed from outside, like any vascular ring or sling, like double aortic arch, any other abnormality that is constricting the bronchi from outside, that can also produce wheeze. The same phenomena, right? Because of this constriction, it is difficult to get out, let the air out. And also mediastinal lymphadenopathy. See, lymph nodes compressing the bronchi leading to obstruction or narrowing the airway caliber. Another one is esophageal foreign body. So intrinsic airway anomalies. See, intrinsic airway, like airway abnormalities, like it could be like airway hemangiomas, any cystic adenoid malformations. It need not be like always the wheeze is due to obstruction by some edema or inflammation. It could be like any other anomalies also, like bronchial or lung cyst, congenital lobar emphysema, any aberrant tracheal bronchus, sequestration of lobe of lung, and also in particularly congenital heart diseases with left to right shunt, where pulmonary edema causes, that leads to bronchial lymphatic obstruction and also bronchial edema leading to cardiac wheeze, and also foreign body. These are all the causes. You have to have an idea. These all entities can also produce a wheeze. That not only inflammatory causes wheeze. These are all the other probable entities that the child may present to our OPD with the wheeze. And also immunodeficiency states can also produce. Mucociliary clearance disorders where cystic fibrosis, there what happens is like obstruction of bronchioles will be there. Primary ciliary dyskinesias where cilia are abnormal resulting in obstruction. And also bronchiectasis, here also there will be damage and permanent dilatation of the bronchi with subsequent obstruction. These are all the mucociliary clearance disorders resulting in a wheeze. Aspiration syndromes, another entity. Even in anaphylaxis like angioedema also you can have your wheeze. Some drugs can also cause. Those are ibuprofen, aspirin, rifampicin, and erythromycin. Others are like inhalational injuries due to burns. Because all these causes obstruction to your bronchi or airway wall edema leading to your entity called as wheeze. So till now we all discussed regarding what are the probable causes, what are the differential diagnoses that a child presents to you with your wheeze. See, this is acute bronchiolitis. We'll discuss in later slides with in brief. Just in brief, I'll tell some points here. Like it is an acute inflammation of the airways, predominantly a viral disease. More than 50% of cases are due to respiratory syncytial virus. Other viruses are like metapneumovirus, adenovirus, influenza and parainfluenza virus. More common in males who are not breastfed. So breastfeeding is very important. Living in overcrowded areas. And also LRTM manifestations are minimal in older patients in whom bronchial edema is better tolerated. The meaning of this line is like acute bronchiolitis usually manifests in age group of 2 months to 6 months. The severity will be more during that age group where the bronchial edema is less tolerated and more vulnerable to all the clinical features of this particular entity. Next, what happens is like in respiratory infection, the most common cause, that is more than 50% of bronchiolitis, is due to respiratory syncytial virus infection. What happens exactly? It is like a more of a complex immune response. First of all, the eosinophils, you all know eosinophils, they degranulate, releases eosinophilic cationic protein. That cationic protein is a cytotoxic, that is, it is toxic to cells of the airway epithelium. So what happens? There will be destruction of airway epithelium. This is one mechanism. And also another entity is Ig antibody release. This also Ig antibody release leads to wheezing. And other mediators that are response in this complex immune response are chemokines like interleukin 8, macrophage inflammatory protein, leukotrienes, and interferon gamma. This all typical complex immune response results in bronchial obstruction with edema, mucus, and cellular debris. The first point you have to remember is the eosinophilic cationic protein is the cytotoxic thing to the airway epithelium, so resulting in cell damage. So subsequently what happens, and other immune complex mechanisms also taking place, resulting in bronchial obstruction. We already discussed the same entity. When the radius is decreased, automatically the resistance will be increased. So what happened? During inspiration, air trapping will be there. During expiration, air will not come out, right? So resulting in hyperinflation, subsequently followed by atelectasis. So all these causes leads to ventilation perfusion mismatch. So because of this ventilation perfusion mismatch, what happens is hypoxemia, that is resulting in reduced oxygen levels in your arterial blood. So further deteriorating the condition, that it leads to hypercapnia. Hypercapnia is a in impending respiratory failure. It is due to severe obstructive disease and resulting in respiratory fatigue. So what happens initially, because of this obstruction, air trapping will be there, and finally there will be ventilation perfusion mismatch, leading to hypoxia and hypercarbia. So it is not a that simple entity. We have to treat it immediately. Another thing is we already discussed, another important cause is asthma due to wheeze. We already discussed these three names. What is transient early wheezer, persistent wheezer, and late onset wheezer? See, we have to know all these definitions. What is a transient early wheezer? It is seen in 20% of population. It occurs before the age of 3 years, had wheezing at least once with LRTI, but never wheezed again. So you have to know whether the child is a transient wheezer or not. In your history, if the child, for suppose some 5 years presented with you with wheeze, you have to know in the previous or preceding history whether the child had a wheeze or not. If the child had a wheeze at least once with LRTI, only that episode the child had, no other episode of wheeze again, then we call it as a transient early wheezer. Only once with LRTI before the age of 3 years. So persistent wheezer, here the child had wheezing episode and the child still wheezes at 6 years of age. This is called as persistent wheezer. So you have to know the difference. What is a transient? That is less than 3 years of age. 3 years of age, the child has had a wheeze with LRTI, but subsequently the child never had wheeze. In a persistent wheezer, it starts before the age of 3 years and continues till the age of 6 years. By the time of 6 years, the child is still having wheeze, then you call it as a persistent wheezer. Late onset wheezer, no wheezing by 3 years. See, so the child never had a wheeze at the age of 3 years, but wheezes at the age of 6 years, then you call it as a late onset wheezer. The remaining 50% of children had never wheezed by 6 years of age. So this is the entity: transient, persistent, and late. I hope I'm clear with all these definitions. Am I clear?
Yes, ma'am.
Okay. So we already discussed there are chronic infections like cystic fibrosis, bronchiectasis, immune deficiencies. In these also we get a wheeze. Chronic infection should be considered in infants who seems to fall out of range of a normal clinical course. Here, in chronic infections, apart from this, you have to physically examine the child as a whole. Then you can get a clue. Like in a chronic infections or in a bronchiectasis, you can appreciate clubbing. In cystic fibrosis, you expect some malabsorption, failure to thrive, and electrolyte abnormalities. And the important thing is they are resistant to bronchodilator therapy. Congenital malformations, we already discussed. Any anomalies like any vascular rings or vascular compressions that are compressing trachea and esophagus from outside can also produce wheeze. Serious causes in why in a congestive cardiac failure we get a wheeze, that is like due to lymphatic and bronchial vessel engorgement leading to obstruction and edema of bronchioles, subsequently producing wheeze. Here in this entity, the child will not respond to bronchodilators because the problem is not due to any hyperreactivity or due to vessel wall abnormalities. Here the problem is like pulmonary edema. So here in a cardiac wheeze, we treat with diuretics to get rid of all the fluid retained in the pulmonary capillaries, resulting in decrease in wheeze. Another important thing is foreign body aspiration. It is common between 2 months to 4 years of age. Infants may present with atypical histories or misleading radiological and clinical findings. See, one should not confuse asthma with your foreign body. And one more thing, during your foreign body aspiration, the child, rather than wheezing, the child usually presents with stridor. So you have to differentiate whether it is due to stridor or a wheeze, whether it is stridor or a wheeze, then only, and also get your x-rays of AP and also lateral views. Gastroesophageal reflux. Here what happens, it can cause direct aspiration into tracheobronchial tree, right? The whatever food ingested that is getting back into your larynx and trachea and bronchi, it may trigger a vagal or neural reflex, resulting in airway resistance, thereby airway reactivity. This can also called wheeze. So these are all the atypical presentations. So the child with GRD may present with wheeze. Child with cystic fibrosis can present with a wheeze. Child with chronic infections can present with a wheeze. Child with congestive cardiac failure can present with a wheeze. Child with congenital anomalies, either intrinsic or extrinsic, can present with a wheeze. And typically the conditions you know that the child presents with a wheeze are bronchiolitis and bronchial asthma. So the topic is to emphasize that the wheeze is not only due to specific entities, there are very varied causes. So one have to be kept in mind while you are approaching a patient that is presented in your OPD department with a wheeze. So other causes like trauma and tumors. These can also, like aspiration, we already discussed the neural mechanism resulting in airway resistance and also resulting in airway reactivity. Aspiration, burns and scars can also cause airway wall edema leading to bronchial obstruction and also wheeze. So coming to the clinical manifestations, how do you approach? What do you ask in your history and physical examination? So you need to ask from your birth history. We have to know what are the weeks of gestation, any history of NICU admissions are there or not, because to rule out any bronchopulmonary dysplasia, when the child is a preterm like 28 weeker admitted in your ICU for prolonged duration, then also the child will have more prone to have bronchiolitis. So one should ask all this history, any history of intubation or any oxygen requirement, because history of intubation, what will happen, the most common complication is like your tracheomalacia. So that can also cause your wheeze, and also maternal complications one should ask, and also history of prenatal smoke exposure, because they are more prone to have wheeze in their childhood. Past medical history, any comorbid conditions, and also whether the child is obese or not, and also syndromic association one must ask. Coming to your social history, these are all the risk factors the child may have wheeze, that is environment history of smokers, any overcrowding is there or not, what is the occupation of inhabitants at home, any history of tuberculosis exposure, or the surrounding areas are having any pets or not. This is regarding your social history and also environmental things. And one more thing is family history. So when you are asking your history, you have to start your birth history. So you may get clues from there itself, because in a cystic fibrosis, the first clue that you get is like the child will not pass meconium during their initial days of life. So each and every point is very important, because getting an accurate diagnosis or narrowing your diagnosis is very difficult when you are in a hurry or jumping only to your clinical features or in your history. So history should start from your birth. Family history of cystic fibrosis, one must ask. Any history of immunodeficiencies like Job syndrome, history of asthma in first degree relatives, or any other recurrent respiratory conditions should be obtained when you are taking your history. So what is the risks of family history of atopy? No family history, 16%, the child may get this. If a single parent atopy, 22%. If the single parent is the mother, the maternal atopy, that constitutes 32% of child is having the same similar findings. If both parents are atopic, then the chances of getting atopy is 50%. So that's why family history is very important, and also related to maternal history and also first degree relatives. So next is, did the onset of symptoms begin at birth or thereafter? One should know what is the time of onset of these symptoms. Is the infant a noisy breather? And when it is most prominent, what is the period it is more prominent, or any variations like diurnal variations or anything, one must ask. Is there a history of cough apart from wheezing? Purely the child is wheezing, or the child is also having history of cough, that also one must ask to rule out all the lower respiratory tract infections. See, wheezing is only the particular thing is like it is hyperreactivity of airway. It is nothing to do with your lung parenchyma, right? So cough involvement is not just a hyperreactive airway, but it can also involve your parenchymal things like in pneumonia, and also in bronchiolitis also even sometimes parenchyma will be involved. So history of accompanying cough along with your wheeze should ask. Was there an earlier LRTA? Is the child is having this is the first episode or previous history of lower respiratory tract infections to rule out chronic conditions? Have there been any emergency department visits, hospitalizations, or ICU admissions for respiratory distress? To know the severity of this disease and also to know the recurrences, how often the child is getting their hospital visits or OPD visits with these episodes of wheeze. Is there any history of eczema to rule out atopy? How is the infant growing and developing? Because I already discussed chronic conditions, the failure to thrive you expect, malabsorption you expect, vitamin deficiencies you expect. So you have to know the growth of the child, and also is there any associated failure to thrive one must appreciate during your history and physical examination. Is there failure to thrive without feeding difficulties? Because even in GERD we get a wheeze, like, right? We get a wheeze in GERD because of this increased reactivity of airway. In that condition, the feeding will be very difficult. Like the child is unable to take feed properly because of the exaggerated reflex. So one must assess. And also like even in H-type tracheoesophageal fistula, this failure to thrive is more common. And also the child more prone to wheeze. Are there any signs of intestinal malabsorption, including frequent greasy or oily stools, to rule out malabsorption syndromes leading to this, like cystic fibrosis and all? And also, what was the gestational age of delivery? This already we discussed. Was the patient intubated as a neonate? This also we discussed to rule out any bronchopulmonary dysplasias during the neonatal period, as well as like prolonged intubation can also cause tracheomalacia. Does the infant bottle fed in the bed or crib, especially in propped up position? Because bottle fed babies are more prone to GERD. And one more thing, breast milk prevents all these conditions like asthma, atopy, and eczematis conditions that you are very well versed. So you can get an indirect clue that whether the child is on breastfed or bottle fed. Are there any feeding difficulties, including choking, gagging, arching, or vomiting with feeds? This is called as typical with GERD. So that syndrome that associated with this type of GER is called as Sandifer syndrome. It's a new terminology for you people. No need to remember, but even in exaggerated GERD, you can get a condition called as WHEEZE that you should know. Any history of new food exposure? Why you should ask this? Because any new food exposure could relate the child with WHEEZE due to atopy. So, is there a toddler in the home or lapse in supervision in which foreign body aspiration could have happened? So, always foreign body aspiration should be there in your mind, particularly the age group of a toddler, 3 to 6 years, because they are very they'll put everything in their mouth. So, we cannot expect at any point one must suspect foreign body, especially if sudden onset of cough, sudden onset of noisy breathing, one should rule out foreign body aspiration. So, next till now, you took everything history related to all the conditions we discussed till now, like all the differential diagnosis to elicit what could be the particular reason. After that, you need to examine the child, right? So physical examination, any respiratory case, you start with your respiratory rate. So you have to see what are the vitals, how is the respiratory rate, what is the saturation. After that, your physical examination is done. So go with your growth charts, any failure to thrive is there or not. Then subsequently, you should look for skin for any eczema and also any other atopy related lesions are there or not. And also any midline lesions that may be associated with your intrathoracic lesions that one have to look for, and clubbing, because in cystic fibrosis and chronic bronchiectasis you expect clubbing. So what are the signs of respiratory distress? Am I clear? Am I clear?
Yes, ma'am.
So now someone tell me, like, you are sure I'll pick the number. What are the signs of respiratory distress? If the child is having respiratory distress, like in your respiratory examination, what will you see apart from your tachypnea? Like respiratory system examination, what can you observe? Here it is there, you can read out even. Roll number 115. Just anyone can speak out. Here only it is there, signs of respiratory distress, tachypnea, followed by, just someone read it out. Someone answered me, right? Just someone
Nasal
read,
flaring,
because yeah.
tracheal tugging,
Okay. How do you mean by tracheal tugging? Followed by what is this? SCR, ICR?
Subcostal retractions or
Yeah.
intercostal.
You see, subcostal retractions are, this is very much important, because only airway obstruction usually causes subcostal retractions and suprasternal retraction rather than intercostal retractions. Intercostal retractions are like more of parenchymal involvement, like you see in pneumonia. So in a child with WHEEZE, like especially like bronchial asthma, you observe subcostal retractions and suprasternal retractions with accessory muscle usage like flaring of ala nasal. If you see particularly case of bronchial asthma, you can appreciate. For suppose if the child presented with you with more of intercostal retractions, that typically tells you the problem is with parenchyma. The parenchymal diseases are like pneumonia. So you can appreciate in your clinical examination what could be the cause, whether it is due to airway or whether it is due to parenchymal involvement. That is very important. So more of subcostal retractions and less of intercostal retractions you observe in a case of asthma. And also we already know prolonged expiratory time. Because the wheeze is heard in expiration, it is due to bronchial obstruction. There's a prolonged wheeze you can observe. And expiratory whistling sounds. In auscultation, you should know what are the type of breathing, whether it is polyphonic wheeze or monophonic wheeze. Sometimes You see, you couldn't appreciate any sound. That is like, you should not be very happy. See, something is, for suppose if the child presented to you in your emergency department with wheeze, all of a sudden the child is not having any wheeze, then you should not be satisfied. See, that part of air is also obstructed, so there is no point of air getting in or getting out. So if there is no channel of air getting in or getting out, there is no point of getting any other sound. So that tells you like impending respiratory failure. So in your auscultation, typically you found wheeze. For sometimes like in complete airway obstruction, you could hear nothing. So at that point of time, you can give your bronchodilators. What after giving bronchodilators, the silent chest will produce some amount of noise called wheeze. That it is a sign that airway is getting opened. So with this of trial of bronchodilators, you can estimate what it is, or you can probably open your obstructed airway. For suppose if you give your bronchodilators and the wheezing is not at all getting improved, one must suspect the stridor, that is extrathoracic airway obstruction, that will not respond to your bronchodilators. So a trial of bronchodilators will give you so many factors, like see intrinsic airway anomalies like any hemangiomas, or any extrinsic compression like any vascular slings. You couldn't get any response to bronchodilators. Usually bronchodilators, where will you get response? Like any bronchial wall edema or any hyperreactivity. Only those conditions with the opening your bronchi, some airway gets relieved, and also all this mucosa and everything will be sorted out, or else there is no point of continuing bronchodilators if there is no response to bronchodilators. So air trapping, what are all the signs? We all know air is getting in and it is struggling to get out. So when air is there in your lungs, what does, like you all know, whenever there is a fluid, there will be no sound. When there is an air, almost it likes a nuisance or nonsense, right? Like it produces hyperinflated chest, barrel chest because of well expansion of your lung fields, and it is resonant on percussion. There is also loss of cardiac dullness. Liver is pushed down. So Hoover sign, there is normal diaphragmatic movement. Hyperinflation, what will happen is diaphragm is flattened. Diaphragm contraction leads to paradoxical inward movement of lower intercostal area during inspiration. This further hampers your air entry. This acute bronchiolitis. So coming to your diagnostic evaluation, what are all the things you need to do to diagnose this condition? So initially evaluation depends on likely etiology. So get an X-ray done, whether any hyperinflation of lung fields are there or not, or any changes suggestive of chronic diseases like bronchiectasis, where you can appreciate honeycomb appearance, any focal infiltrates. So X-ray gives you a clue. See, but in bronchial asthma, the diagnosis is mostly clinical. Usually we couldn't find anything apart from your hyperinflation of lung fields, but the child presented with you with wheeze with other possible etiologies, then you have to look for all these conditions. Another one more thing is trial of bronchodilators. I already discussed. It is both diagnostic as well as therapeutic in bronchiolitis and asthma, where bronchial edema, all these are there. It won't affect any fixed obstructions like any foreign bodies. There is no point of giving bronchodilators. And also continuously repeated giving of bronchodilators even may worsen wheezing in tracheal and bronchomalacia conditions. Baseline immunity in complicated cases, when you suspect immunodeficiencies, you can get the baseline immunity profile. Structural problems like upper airway obstruction, go with a rigid bronchoscopy. So any esophageal diseases like GERD, go with your barium swallow, pH probes, and upper endoscopy. Primary ciliary dyskinesias, very rare, and these are very high-end investigations. You doesn't know at this point of time. If the child is having to have tuberculosis, go with your Mantoux test and gastric lavage, bronchoalveolar lavage fluid, culture microscopy, and PCR. Bronchiectasis, the gold standard for bronchiectasis is HRCT, that is high resolution computed tomogram scan, to get a better delineated profile of all the airways, where you can appreciate honeycomb appearance, that is like due to permanent dilatation of your bronchi. Next is for cystic fibrosis, go with a sweat chloride test, nasal potentials and genotypes. Systemic immune deficiencies like IgG subtypes, lymphocytes and neutrophil function. These are very high-end investigations, but you have to know when you are writing your answer or any case with approach to WHEEZE, with appropriate history, you'll get almost most of the information. When you are suspecting these particular entities, then go with the appropriate investigation. That is not like when a child presented with you with WHEEZE, don't go with all the investigations. With the appropriate relevant history, you'll get struck at some point like this could be like cystic fibrosis, or this could be like immunodeficiency, or this could be like tuberculosis. So when you are particular entity, then go with the specific diagnostic test for that particular disease, not like whole dictum like to do everything. Baseline chest radiograph is must, followed by specific disease related investigation after your proper history and examination. That's why exhaustive class was taken regarding what could be the probable history and what could be the probable physical examination points. Cardiovascular diseases, in congestive cardiac failure, in congenital heart diseases, you get like pulmonary edema. Then go with echo and angiography. Viral testing, usually this diagnosis is like uncertain, you cannot get every time the PCR viral cultures, but if at all any feasibility is there, go with your viral testing. Treatment, first of all, you need to comfort the child. Try to keep your baby calm. Having a cough and a noisy wheezing frightens children, and breathing is more difficult when they're upset. See, don't try to give your all these things with masks. Oxygen one must provide, but not in a threatening manner. It also further increases the resistance to airway. Offer frequent fluids. Drinking less but more often may be easier. Bronchodilators we already discussed. The first thing we administer is beta 2 agonist and observe the response. Children with less than 3 years, give with a mask and spacer. Mask should be there because the child is unable to coordinate without any mask. And if therapeutic benefit is demonstrated, therapy to be continued in all asthma patients with exacerbation with viral illness. Ipratropium bromide, this is an anticholinergic drug. This is also used as a bronchodilator along with your SABA, that is short-acting beta-2 agonist. Next, go with your oral or IV steroids used for atopic wheezing infants thought to have asthma, that is refractory to other medication, and go with steroids. Next is inhaled steroids. These are the drugs of choice in bronchial asthma. So in acute bronchiolitis, what to do? First of all, see, bronchiolitis, it is mostly like more than 50% of cases, it is due to respiratory syncytial virus, right? So viral infections, there is no point of giving any antibiotics or any other drugs. So one have to go with your supportive therapy. The mainstay of therapy is providing oxygen, because what I told you earlier in the class is what happens in bronchiolitis. It is a complex immune response leading to ventilation perfusion mismatch, leading to hypoxia, finally the hypercapnia, leading to respiratory failure. To terminate all these events, one must provide oxygen, that is also cool humidified oxygen, in a non-threatening way. Don't go and jump on the child to give oxygen, because those all leads to airway resistance, because the child will cry more. Avoid giving any sedatives. Keep the head and chest elevated at a 30-degree angle. Inject tube feeds to avoid aspiration. Respiratory decompensation is happening, like a carbon dioxide retention is more, then go with the tracheal intubation. Bronchodilators shows modest short-term improvement in clinical features. Why? Because the most common age group that bronchiolitis presents is like 2 months to 6 months of age. During that period of age, there are no beta-2 receptors, so that to drugs act on. But we give a trial of bronchodilators because recent evidences like with bronchodilators shows some response to bronchiolitis. So we are giving. It also shows some modest short-term improvement, not like long-term improvement. First of all, the treatment is mainly supportive. Along with these measures, we have to give the drugs with bronchodilators or nebulized epinephrine, that is more effective in treating acute bronchiolitis. And also the drug, only the antiviral drug that is there is ribavirin. It is administered in aerosol form. It is not giving in our hospital setup. It is usually used in children with congenital heart diseases and also in chronic lung diseases. No role of antibiotics unless secondary bacterial infection is there. So it is a viral infection. Please don't write in your examination treatment is antibiotic. If the culprit is viral infection, there is no point in giving any antibiotic here. So prevention, what to do? Reduction in severity and incidence of acute bronchiolitis due to RSV is possible through administration of pooled hyperimmune RSV intraimmunoglobulin and also pavlizumab, a monoclonal antibody to RSV F protein before and during RSV season. But this is recommended only for the children less than 2 years of age with chronic lung disease or prematurity. This is not the common drug to prescribe everyone. So there is a particular age limit that is less than 2 years of age and also prematurity. Inhaled corticosteroids and montelukast may be considered in preschool child with a recurrent wheeze. I already discussed what is a persistent wheezer or a recurrent wheezer. So avoid smoking, educate the parents, avoid allergens, and also encourage meticulous hand washing. Prognosis. So what is the prognosis with the child presents with this? Approximately 60% of infants who wheeze will stop wheezing. So 60% you can give the proper assurance, there is nothing to worry, they will stop on its own. If the child is having acute bronchiolitis, highest risk in first 2 to 3 days. Case fatality rate is less than 1%, that is outcome is very good. Death is mostly due to apnea, severe dehydration, uncompensated respiratory acidosis, and mean duration of symptoms is around 12 days. High incidence of wheezing and asthma in children with history of bronchiolitis. So when you are explaining the prognosis, you have to be very cautious in telling this because there is a high incidence of wheezing and asthma with history of bronchiolitis. The child in future going to asthma is like more. In congenital heart diseases, bronchopulmonary dysplasias and immunodeficiencies, more the severity of the disease, there are more chances of morbidity and mortality. Out of this, the bronchiolitis is a self-limiting. Comparatively, outcome is very good in bronchiolitis, but the instance of wheezing and chances of converting or the child having asthma during further age is very high when the child is having bronchiolitis in the initial periods of his life or her life. Thank you. Actually, one more entity is there like bronchiolitis. We covered every point of bronchiolitis in these slides only. Just I'll go through the slides. So same thing, bronchiolitis. Same etiology, clinical features. There is nothing much variation. The management part the same, like oxygen. We already discussed humidified oxygen should be ideal and the saturation should be like if less than 94% with the combination of respiratory distress, one have to provide oxygen and also should be maintained at around above 95%, followed by fluid therapy because severe dehydration is always dangerous to the baby. So maintain fluids like normal maintenance fluid. Fluids can be increased up to 20% if the child is having persistent fever or markedly increased respiratory effort because to prevent insensible water losses and monitor serum electrolytes. We already told you beta-2 agonist therapy, only modest short-term response, followed by nebulized epinephrine that is very efficient comparatively with bronchodilators. Systemic corticosteroids, like data suggests moderate potential efficacy. In higher doses, it decreases hospitalization rates and improves symptoms at 4 hours in the emergency department in patients with moderate to severe bronchiolitis. Ribavirin we already discussed. And one more thing is like child with bronchiolitis, CPAP is very useful because it helps in recruitment of alveoli and it helps in prevent of alveolar collapse. So opening up of airways is very good. So one can try CPAP in bronchiolitis. So this is the end of the session. If you are having any doubts, you can ask me or you can post in the group.